I'm Spencer King. I'm here with Ben Sorica in Amsterdam at the European Society of Cardiology meeting. Some interesting late-breaking trials are coming through, and we're going to talk about a few of them. Ben, what do you think about that trial TASTE?
I know there was a lot of stuff that came out today. The TASTE trial, interesting, 7,000 patients, a little bit more, with ST elevation myocardial infarction, were randomized to either thrombus aspiration before PCI or PCI alone, and really no difference at all in terms of overall mortality. And that was regardless of whether there was a large thrombus burden or not, whether it was an anterior or inferior MI. So it does throw into question, I think, a lot of the data we've been using from the TAPA study about how to best manage these patients with ST elevation MI.
Yeah, so this is a Swedish, Danish, and Iceland study enrolling a huge percentage of all the people who had infarctions, finding no benefit. Now, do you think, is there anything in there that would it help us identify which patients might benefit? Were there any subgroups that stood out? Because sometimes it's said that high clot burden would be appropriate, but I understand there were no real interactions here.
No, nothing came out that the people with the highest burden still did not see a benefit if they had a lot of clot. I think there's additional stuff that will be interesting. I mean, maybe the duration of symptoms before onset, but I think overall a very neutral finding in a procedure that we thought was giving a lot of benefit.
Now, there's another trial that I think tremendously interesting, TAO, which is a 10A inhibitor, which was tested. What did you learn from that one?
So otomixaban is an IV 10A inhibitor, and they compared it against heparin in a large outcomes trial. And the phase 2 study from otomixaban looked promising that there would be reduced ischemic events in the hospitalization phase with otomixaban. But in a large, well-powered study, they didn't see any difference in terms of improved mortality, reduced MI, stent thrombosis, and so it really didn't show any benefit over standard of care.
So negative trials are not useless. They help us understand things, but we have had a couple of them here. Another trial that's named Paris, but actually took place in New York, I think, primarily, is the Paris trial, looking at double antiplatelet therapy and discontinuing or interrupting. What did you learn from that one?
So that was an interesting trial, trying to get a real-world picture of what are the reasons people stop dual antiplatelet therapy after stenting. And so they looked at, I think, about 5,000 patients, and they followed them for at least 2 years. And they determined whether people stopped antiplatelet therapy because the physician said so, or whether it was a short interruption for an intervening procedure, or if it was due to some disruption because of an intercurrent illness or something else. And I think the most reassuring part of that was that discontinuation of dual antiplatelet therapy, whether it was at 6 months or 1 year, was guided by the physician, did not have any increased risk of subsequent cardiovascular events. So I think following the guidelines and using your clinical decision seems to be a appropriate way when determining the length of dual antiplatelet therapy.
Good. Now, if we jump from the heart to the veins, to the periphery a little bit, there's a Hokusai VTE, the venous thromboembolism trial. Again, trying to understand whether warfarin or other agents, 10A inhibitor agents, will be helpful for lower extremity venous thromboembolism. This again was a negative trial overall, but there were some signs here for a benefit, right?
There were. So this was looking at edoxaban, sort of the third of the oral 10A inhibitors, compared to Coumadin in patients with pulmonary embolism VTE. And again, it showed non-inferiority, so neutral but also non-inferior to warfarin, and it did seem to have a better safety profile. There was left bleeding, and I think even in the patients with the most symptomatic pulmonary emboli, there still was similar efficacy with Coumadin. So I think it is important. It's expanding the use of the oral 10As into the venothromboembolic disease and giving more options.
Now, there's been a lot of enthusiasm about substitute for warfarin in atrial fibrillation, dabigatran. However, now the question has been, what happens? Can you use this for other indications, such as heart valves? So, with the mechanical heart valve, this agent was tested, and it comes up empty again, huh?
Exactly. I mean, I think it's always important to remember how were these agents tested in their studies. And we have a lot of experience in non-valvular atrial fibrillation. We have a lot of experience now in venothromboembolic disease. And the use of these new agents are very well described in those particular populations. But when we start looking at areas that have not been studied, where Coumadin is used, like valves, we really see that we have a lot to learn. And I think the fact that there was an increased risk of strokes and complications with dabigatran in mechanical valves is a very important warning for everybody to always know what your indication is and know exactly what your anticoagulant has to be for that indication.
So the name of this trial is Realign, but I take it we're not realigning based on the results.
I think we are realigning with Coumadin for that now.
Yeah, very good. There were some trials also today that had to do with lifestyle. And briefly, let me tell you, 4 trials. One of them looked at summer versus winter in terms of risk factors. Turns out people are thinner, lower waist circumference in the summertime, and they have lower blood pressure. In addition, the second trial observation showed that the temperature was important for heart attacks. I think I'm remembering my old Netter picture of the guy shoveling the snow, and so that's not news to me. Exercise for the unfit. Turned out that fit people didn't make so much difference, but the unfit people who then tried to exercise, they thought that was a benefit. And finally, music is good for you, but only music if it's enjoyable. So it's probably personalized music.
So we should go to the symphony in San Diego and stay there for work.
I would choose that one as well. So this is today. This is for Cardiosaurus. Stay tuned. We'll have more results from the trials here in Amsterdam in the near future.